Welcome, everyone. You should have had a second to read through these housekeeping notifications, but again, just a couple of reminders. Welcome. Today, we will be using the chat function for question and answers at the bottom of your screen. If you have any IT issues, send a message through the chat, and the session is being recorded. So hello, my name is Sarah. I am here with Assist International, helping with the back end of this session as our esteemed colleagues lead us today. Welcome to session 6 of the Oxygen Therapy and Critical Care Case-Based series. Today, we will be discussing the basic ICU care considerations. And now I'll introduce Dr. Papytcho, our lead panelist today, and he will get us started.
Thank you, Sarah. Good afternoon, all the participants, and thank you for joining us on today's session. Today's session is all about the basic consideration of ICU. I'm not alone. I'm with my two great friends, Dr. Opiri, critical care specialist at Mainasoko Hospital, together with Dr. Sipuka Ndaba, anesthesiologist and critical care specialist at Mainasoko Hospital. Let me inform you that today's session, the moderator will be Dr. Sipuka Ndaba. Dr. Sipuka, thank you very much for being available. I know that you are so busy. In your background, I can hear the door is being knocked every hour and then, but I hope you have enough time to finish with us this session. But if you have any points, duty calls you, just let us know and then we know how to do it.
Thank you so much. Thank you so much, Papytcho. Welcome everyone to this very, very important session where we will be discussing on basic ICU care considerations. As you may be aware that currently all healthcare providers need at least some basic skills in critical care. It's inevitable because when we talk about COVID and we look at the way the pandemic is unfolding, you would agree with me that most of the patients that we are admitting have severe symptoms, and a good number of those are critically ill patients who may benefit from critical care. So you also agree with me that all hospitals, irrespective of which region, district, have critically ill patients. And so we realize that the number of intensive care units or critical care units is not as available to cater for all the patients that are critically ill. Therefore, this session will discuss, or rather share ideas that we can use to make recommendations in our various facilities on how best we can set up critical care environments or units with the minimum resources that your hospital or facility can mobilize. So if we have the basic knowledge, then we would know definitely the kind of resources that will be required for us to set up even just small, maybe 2-bed or 3-bed critical care space where you will be able to take care of these critically ill patients. So again, I would like to remind you the participants that we have the Learning Resource Center with a lot of literature and material on this subject. Please feel free to log in and read the details that we may not be able to capture within this short period of time that we have. So with that said, I would quickly want to introduce you to the case that is going to act as a discussion point. A case of Mr. T, a 46-year-old man who presents with hypoxemia and respiratory distress. You would agree with me that with the current COVID pandemic, we've all seen patients who present with this kind of clinical symptoms: hypoxemia, they are desaturating, as well as respiratory distress. So we're going to use this case to guide our discussions. So at the end of this session, our practice change objectives will include, we'll need to identify the minimum standards of an intensive care unit, the bare minimum things that you will need to set up a critical care unit in terms of healthcare providers, in terms of the type of equipment and monitoring systems that you will be required in your high care setting. We'll also list the most common indications for ICU admission. This is always a very, very thorny issue as to which patients would benefit from ICU admission. So I'm sure Dr. Piri will be able to touch very clearly on some of these common indications. We also need to understand and prevent the most common complications that occur in ICU patients. And then at the end, we'll review or develop and implement ICU care bundles that we can implement to prevent some of the common complications that occur in patients that are admitted to the critical care unit. So with that introduction, I would like to invite Dr. Piri to set the ball rolling and discuss the initial presentation of the case, as well as cover the definitions of ICU. Thank you very much, Dr. Piri. Over to you.
Okay. Thank you so much, Dr. Ndaba. As highlighted, the case for today is Mr. T, a 46-year-old male with a history of obesity, type 2 diabetes, who has come to our emergency department with a 3-day history of shortness of breath, cough, and fever. I think in this time of COVID, this is a common presentation of most of our patients. When you examine Mr. T, he appears well. His breathing is not labored and is able to complete full sentences on speaking. His past surgical history is really unremarkable. He had a lap for cholecystectomy in 2012. He does not smoke, does not take recreational drugs, nor does he drink. But he reveals that he stays with multiple family members. He works in an office. He's got a smart job as a water engineer. When you take his vitals, what is revealed is that his heart rate is slightly tachy. It's at 98 beats per minute. The blood pressure is 127/63. Respiratory rate is at 30 breaths per minute. His temperature is currently normal, 36.5. However, his oxygen saturation is at 87%. So because you're a good doctor and you've recognized that this patient is laboring to breathe, you decide to put him on supplemental oxygen via a non-rebreather mask at 10 liters per minute. And upon doing that, his saturations improve to 92%. Sarah, can you please go down? Okay. So immediately you do this because you're a good emergency doctor. You decide to call ICU because you recognize that this is the patient who has potential to deteriorate. So at this point, I'm going to pause and ask, what is an ICU? I think this is a question which a lot of us as clinicians, as nurses, as medical doctors, as healthcare workers, this is something that we're exposed to at some point in our career, and more so because of the COVID pandemic. So if you look into that word crowd, which we have before us, we can see words such as monitoring, life-threatening, system, critical, services, management. So all of these are the thoughts that come to our mind when we're talking about ICU, what an ICU is. And there is no standard definition for an ICU, as you will see during the presentation. But what should come out is an ICU is a place of support, organ support, treating life-threatening conditions, and while ensuring there's monitoring going on. Sarah, please go down it. I will also mention, if we remember the last presentation, we talked about the difference between intensive care and critical care. With intensive care and critical care, the most important aspect is to provide care in a time critical manner. So the time frame, the time reaction frame is what is important and is what will save our patient from further deterioration. So if you look at today's practice change action, we want to identify the minimum standards of care in an ICU. There are various definitions which have been put in place by different authorities. However, there is no consensus, as you will see further in the discussion. The World Federation of Societies of Intensive Care and Critical Care define an ICU as an organized system which provides care to critically ill patients by providing intensive and specialized medical and nursing care while enhancing the capacity for monitoring. So monitoring is very important, and being able to give multiple modalities of physiological organ support while sustaining life during a period of life-threatening system insufficiency. So this is quite a mouthful. This is quite a mouthful in terms of definition. However, before we move on with the rest of the discussion, I just want to take you back to what the World Federation of Societies of Intensive Care and Critical Care have said. So ICUs are a relatively new phenomena in medicine. We've seen modern ICUs evolve in the past 69 to 70 years. They started a good 70 years ago. And what is important is that ICUs are stratified based on the intensity of care that they can provide to a critically ill patient. So here, you're talking about having an organized system for care of these patients. Usually, with intensive care, this is a well-defined geographical area within a hospital. Even though the activities, they'll extend beyond this geographical location, activities of critical care can extend to the operating room, in the post-anesthesia room, in the emergency department, in our general wards. And all of these aim at giving time critical care. ICUs are stratified according to the level. The common classification that we'll see is a level 1, level 2, and level 3 ICU. So just in a nutshell, the discrepancy in terms of level 1, we're talking about the most basic ICU care. So this is an ICU facility which is capable of providing oxygen therapy and oxygen support to patients. It can consider using non-invasive monitoring, so your non-invasive blood pressure, your pulse oximetry, as we'll go through in the next aspects of the discussion. However, the care that is given, the medical and nursing care, is more intensive than what would be given on a general ward. So that is our level 1 ICU. And if you look at this definition, this is something that all of us can advocate for as high care beds in our hospitals or acute bays. The next level in terms of stratification is our level 2 ICU. So in terms of level 2 ICU, you're talking about a unit which is able to provide invasive monitoring. This unit is able to provide basic life support, even if it's for a short period of time while waiting for a patient to be evacuated to a level 3 ICU. So the hallmark is your invasive monitoring and your basic life support for a few hours. The most advanced or sophisticated is your level 3 ICU. So here you've got a full spectrum of monitoring and life support strategies. So usually these would be regional in advanced countries. So these would be regional. So this is a center for critically ill patients in the region. However, an added role is that for these centers, they should be able to provide all of these life-saving modalities for an extended period of time. They're also actively involved in developing critical care research and evidence, so improving the care, generating evidence for other centers to use. So in a nutshell, those are the 3 stratifications of ICU. I just want to briefly mention as well, I think participants may have come across the concept of an open ICU and a closed ICU. So in most of our facilities, we run hybrid ICUs, but the difference is that in an open ICU, you have each specialty team has full admitting rights of the patients that they refer to the ICU, and they do consult an intensivist. So the intensivist on the unit merely consults with the specialty unit. So a patient can be referred from internal medicine, from general surgery, from the emergency department. While in closed ICU, these ones are rare, I think, in our country. Here, the admitting physician is the intensivist, and they have, they consult other disciplines, but the general care of that patient would lie with the admitting intensivist. So in a nutshell, that is it about, that's it about intensive care and the levels. So I'll go back to the presentation, and I want us to look at the standard components of an ICU. So we have a question there. It reads, which of the following are standard components of an intensive care unit? So please, participants, feel free to click on the answer which feels appropriate to you. Okay, under 30 seconds, please. Okay. Okay, thank you so much. So far, we've got 24%, 24% of 24 people participating in the poll. And I think you're right. The answer is 6, all of the above. So when you're talking about the minimum standards of care in an ICU, you need to ensure that you have continuous monitoring. You've got specialty treated, trained healthcare. So healthcare workers should be trained. You've got a system of delivery, time critical care. So the onset of action or the onset of the care is very important. You need specialized equipment. You need rapid access to diagnostic services and therapeutics. So I think 6 is the more appropriate response. Okay, Sarah, can we please go down? Okay, so the next practice change option, practice change action point number 2 is for us to identify who are the key healthcare providers in an intensive care unit. So just as an update with our patient, Mr. T. Mr. T has been on oxygen via non-rebreather mask at 10 liters per minute. However, his saturation has now dropped up to 89%, and his respiratory rate has increased to 32 breaths per minute. Remember, he was able to speak full sentences a few minutes ago, but now he can only speak to 2 to 3 words at a time. So it brings us to the question, does this patient need to go to an ICU? You could answer this in the chat box. Why? Does he need ICU or why not? Is this a patient who can be nursed on a general ward? As you are answering that question, allow me to just share some information from the College of Intensive Care and Critical Care of Australia and New Zealand. This is a paper which was published to look at the minimum standards of care that an ICU should have. So this paper just highlights the resources that are required for you to provide safe patient care to patients who are critically ill, so as to ensure the best outcome, regardless of the level of ICU that you have. So the requirements are very different depending on the level of ICU. However, there are certain generics, what I'll call generic requirements. For you to run an intensive care unit, you need to make sure that you've got staffing. The general composition of an ICU is that one, you would have medical personnel, you need nursing personnel, you need auxiliary staff as well. So that's in terms of staffing. Medical personnel, you need an intensivist. Either this could be someone trained in critical care, it could be a physician, there could be doctors who have specialized in critical care as well. You need critical care nurses to be lead in charge of nursing care. And these can be trained, post-registration trained, or experienced nurses. We cannot ever emphasize the need of auxiliary staff. You need your physiotherapists, you need your biomedical technician, you need your nutritionist, you need your lab support, your pharmacist, radiography, you need your clerks to make sure that your record keeping is intact. You need cleaning staff, you need porters, environmental health, counselors, the clergy, because we know what the spectrum of ICU or critical disease is like. Other generic requirements in terms of ICU include a dedicated structure as well. You need a site with the appropriate building, design. You need equipment. You need monitors. You need monitors of the monitors, or monitors of the equipment. You need portable equipment. And these are part of the generic requirements that you would need as you are setting up your ICU. So to go down to the next question, I'll ask this as a poll, Sarah. Which of the following are essential staff for an ICU? Please, participants, you can click. Okay, thank you for the answers. Sarah, you can end the poll and share the results. So as per discussion and the generic requirements that we've talked about, when you're talking about essential staff for an ICU, you're talking about a whole complement of healthcare workers who complement each other by their roles. By working synergistically, we're able to improve the patient outcomes in an ICU. So all of the above are very important when it comes to ICU care. Sarah, we can just go down, please. Okay, so before I invite Dr. Papytcho to take over with the next component, which of the above providers could improve the care of Mr. T? How and why? I think this question is a repetition. This is something that we've talked about already. You need a whole complement of staff. But one question that I would like to pose to you is, what percentage of high care beds or intensive care beds does a hospital need? This is something, I think this is something that in developed countries, we've been very slow to catch on. It is recommended that up to 5% of hospital beds are dedicated to critical care or intensive care. And the ratio should increase up to 10% in university teaching hospitals. So 5% of hospital beds should be dedicated to critical care, and 10% if it is a teaching hospital. I would like to ask Dr. Papytcho to take over with the discussion. Dr. Papytcho, please.
Thank you very much, Dr. Opp, for a wonderful discussion. You've taken us to what is an ICU, and then from that discussion, it's now easy to understand what type of monitors, what type of equipment you might need in your ICU based on the level of care that you are giving. So our practice change action item for this time is to discuss the type of monitors needed in an intensive care unit. As we know, ICU is a place where make a difference with other wards because of the type of equipment and the monitors that are used in there. But there are basic equipment that are needed that should not miss in every ICU, and other specialized equipment, they come with the needs that occurs or the type of care that is given in each different unit. So a case updates, Mr. T is transferred from the emergency department to the ICU after evaluation by the ICU physician. As everyone answered in the chart that the patient needs ICU admission because it's deteriorating. He is placed in an isolation room with negative pressure, person under investigation for COVID-19. He continues oxygen therapy with the non-rebreather mask, but the flow has been increased to 15 liters per minute. There's an aspect that I want to bring up in this, in the case update, when we talk about negative pressure room. Remember in the last discussion a month ago, we said for isolation, there are other institutions where they have a special place with a negative pressure where they put patients with a type of airborne infection, so that when they are put in there, the negative pressure room, what does it do? It prevents the air in the room from escaping the isolation room. Why? Because outside that room, the air is there, there's positive pressure. So instead, the room is just sucking from outside to inside, but does not release from inside to outside, because the infected room will not infect the air outside. But how does it escape from that place? There are some channel. The air has to pass through a certain type of filters. It filters before it lets out there in the atmosphere for safety and keeping the environment safe or better for everyone. So to continue for our discussion, the question here is, which monitor should be placed on this patient? You admit the patient in the ICU. You say patient need to go there. As we usually say, for close monitoring. When you are sending that there for all those nice indication that we write there, what do you expect to be done on this patient? We can send our discussion point in the chat, and one of the co-panelists will go through and then we'll make a comment on it. So as we know, the principle of patient monitoring in ICU, it does not select one over the other one. The patient should be considered as a whole. Even if this one has a respiratory problem, though more emphasis will be put on there, but when it comes to monitoring, there are key parameters that need to be monitored, even if they are not of the respiratory system. So monitoring a patient in the ICU, you consider all parameters that will give you an idea of the general condition of the patient. So just like you're having a big dashboard whereby you are checking each parameters, to see what is changing on this patient, what is improving. As he came with a respiratory issue, something else can come along. He can get sepsis, affecting kidneys. It can go into shock. The heart can be affected. So monitoring should include all the vital organs. It should include all the key parameters so that you are not missing anything. And the next point to discuss here is which of the following is not a patient monitoring requirement found in most ICUs? As we said, the type of monitor that you get, they depend on the type of care or the level of care that is given in the ICU. So on this poll, participant, please, you can choose the answer that you think is best. Thank you, Sarah. Can we end the poll? Wow. I can see we've got genius here. The answer is correct. So as we said, the most in most ICUs, maybe the word most should have made it a bit more clear to say, all these could be needed in the ICU, but in most ICU, we don't have a transcranial Doppler. You will need a ECG because you want to analyze at every time what is the electrical activity of the heart. You need a pulse oximeter because you need to know what is the saturation of this patient already who's giving you an issue with oxygenation. You need a blood pressure monitoring. This can be invasive or non-invasive. A transcranial Doppler, that becomes a bit more sophisticated. Later on, we will see that there are other types or other level of ICU where such more advanced equipment that are needed for other physiological variables would be used. But this is not a must-have in all ICU. Okay? A respiratory rate monitor is not a point to discuss about. Thank you. We'll proceed with a case update. Patient connected to the monitor, and then you evaluate him, you find that the vitals are like heart rate tachycardic at 102 per minute, a blood pressure 117/52, respiratory rate 32, temperature is 7.5 degrees Celsius, and SpO2 is at 91%. Patient not doing so well. At this time, you might need more aggressive management. You have to escalate your type of management, and you have to choose what is the way forward. Always be open for any consultation. If there's any need for calling for consultation, that should not be a point to discuss about, and then act. The quicker you act, the quicker you consult. As we discussed about the open type of ICU, the challenge that we have here, in terms of numbers, we cannot run closed ICU because we are disadvantaged in terms of personnel. So in addition to patient monitor, what other type of monitors are needed in the ICU? What other type of monitors are needed? This is another discussion point. Monitoring for ICU patients, as you know, the equipment, the machine, quite all right, they can give you a better understanding of, or better view of changes in the vitals, but the best monitor is a bedside nurse. Our colleague, the nurse, when they sit close to the patient, especially for a trained and qualified or an experienced nurse, they will be able to anticipate the patient who's changing condition. Before it deteriorates further, they can alert the treating physician about the patient who's changing condition. So the nurses at the bedside, they play a good role. And later on, in terms of patient monitoring, or in terms of nurses to patient ratio, we'll have a discussion which will tell us what number of patients can a nurse monitor at one time. The other monitor that we might need is the standard patient monitors. The standard patient monitoring, those are the monitor that we usually have in most of the ICUs. They will give you different parameters, the heart rate, blood pressure, respiratory rate. If it's more advanced, it can give you the end tidal volume. It can give you other parameters. Yeah. Sarah, please go up. The other monitor that you might need is monitoring for patient transport. Remember that at some point you might need to move your patient from point A to point B. You cannot disconnect fully patient from the monitor who's critical in the ICU, assuming that you don't have a portable X-ray or a portable ultrasound, okay? Or you want to take the patient for any other investigation that cannot be done in the ICU. You still need to continue monitoring the patient as he's moving outside the ICU. So for that, you need a patient monitoring. Or if the patient being ventilated, you might also need to have a portable ventilator so that you continue ventilation of the patient whilst moving with him within the hospital, or if it's outside the hospital, wherever the patient needs to be moved to, monitoring should continue at every time and everywhere. The other monitoring is the monitoring of equipment. This is another great point that we always have to consider. Remember, you've got equipment. Those equipment, they also need to be monitored. Maybe the question will come here is that, how can equipment be monitored? Yes, it can. So most of this equipment, let's talk, for example, for a ventilator. When you're talking of a ventilator, how can you monitor it? The ventilator, the way they are built, incorporated with a self-control, which comes in terms of alarms. They've got alarms which will notify you when something is wrong, okay? So like that ventilator needs oxygen, and the oxygen should come from a source. So you need something to monitor the type of oxygen that is coming, the pressure of oxygen that is coming from the source. You need something to notify you when there's failure in terms of pressure. So there should be an alarm along the system. You also need an oxygen analyzer that will tell you what type of oxygen, purity of oxygen that you are receiving, okay? The breathing circuit, is the breathing circuit connected or disconnected? When they get disconnected, you need something to let you know that the patient is disconnected, and then let me pay attention to what is happening here, okay? Nonetheless, there's also another monitoring equipment that is needed. It could be a humidifier, which will help you identify or notice when the areas being ventilated, the patient is getting cold or hot. So the thermometer in the humidifier can raise an alarm and then tell you now the air that you're giving, it's below the normal temperature or it's above the acceptable range of temperature. The next point that we would like to discuss here is what is the recommended maximum nurse to patient ratio for critically ill patients in the ICU. As we preempted earlier on, that this will be coming soon during our discussion. Here we are. We would like you to enter this poll and give us the recommended ratio. Okay, thank you, Sarah. I'm sure we can end the poll. Okay, everyone is gone 1 for 2 because it's a less ratio. I wish if we had added 1 to 1, I'm sure everyone should have gone for 1 to 1. Thank you. Sarah, please click on the link. So as we are going through this article, we'll find that, no, not this one, Sarah. Yes, thank you. Yes. What I would like to say is that okay, what I would like to say is that the ratio of nursing to patient play a great role. It has a big impact on the type of care and outcome of patient. In a level 3, as we were told earlier on, that is a high level of ICU, you found that a patient, a nurse to patient ratio, it can even be 1 to 1. You don't want to give so much task to one nurse who's looking after a critical patient, like a patient who's from a post open heart surgery and then unstable patient, or a neuro patient who's very unstable. And those big surgery whereby you see here just a nurse should be allocated to this patient to be sure that things are being done as should be. Okay. So invasive intervention not provided anywhere else in the spinal fluid drainage for ICP or invasive mechanical ventilation or vasopressors, patients who are very unstable needing more than one vasopressors. Such patients, you can allocate them one nurse or minimum or maximum 2 patients. So for a level 2, because there the level of care also trying to be medium to low. For unstable patients who need nursing intervention, laboratory wake up, and monitoring every 2 to 4 hours. You can see that there's quite too much running around here. The nurse might be moving left to right, trying to at the same time do everything. So if you have an ICU with a big capacity and got less nurses, then you have to choose how you place your patient, and also make sure that the patients, they are not far from each other. Not a nurse who's looking after, you give him 3 patients, and then one patient is at bed 2, the other one bed 7, and the next patient at bed 11. You see, she has to run like the ICU for her to attend to the 3 nurses. No, in such case, you arrange that the patients are close to each other, and then it will be easy for her to maneuver around and then do and offer the best care. Okay. So the intervention that are needed is when interventions such as non-invasive ventilation, IV infusion, or penetration of vasodilators. Okay. Yeah. So as you can see, there's no standard ratio. The ratio depends on the level of care that is being given in the ICU. Thank you, Sarah. We can go back. Yeah, we can go up. I think at this point, I'll hand it back to Dr. Ndaba so that he continues with the next point.
Thank you so much, colleagues, for this wonderful discussion so far. So moving on, the practice change objective or action item for the next piece of discussion is for us to be able to list the specialized equipment needed in an intensive care unit. For you to set up an intensive care unit, what are some of the equipment that you would need? So again, I want to encourage our participants that there will be a link that will be shared in the chat box that will give you access to all these materials. So find time and log into the website. You'll find a lot of literature associated with this session. Yeah, so kindly feel free to log into that link and read through the material that we are discussing. So the next question is, which of the following specialized equipment is least likely needed in the care of Mr. T? So we are going to do this as a poll. Let's get your responses about what you think of the listed equipment below. Which of them will have no role in the care of Mr. T? Thank you so much, Sarah. You can end the poll. I think we are happy because the majority of our participants have actually gotten the correct response. So an external ventricular drain may not be necessary in our provision of care for this particular patient that we have. So when we look at this, this list of equipment that has been given to us, you realize that Mr. T is presenting to us with primarily a respiratory problem. He's desaturating, we're administering oxygen, he's having shortness of breath, and so many other symptoms in relation to the respiratory system. So you obviously agree with me that you would need airway equipment. So we'll list down what kind of equipment that we are referring to that you would need to manage his airway. You would probably need a ventilator because this patient, he might go into severe respiratory failure and need to be assisted in terms of breathing. You might need a manual ventilation mask and bag, commonly called an ambu bag. This is important because if you need to assist Mr. T with breathing, when he goes into severe respiratory failure, you may need to ambu bag them as you assist in their breathing. An external ventricular drain, this is a procedure which is done, for instance, in patients who've got hydrocephalus, they've got a lot of CSF in their ventricular spaces, and so you need to drain some of that excess fluid in the brain, and so you insert this external ventricular drain to relieve some of the increased intracranial pressure. And in our patient, this may not be required. A suction apparatus or suction machine, this is required because in the event that you need to intubate and ventilate this patient, when they go into severe respiratory distress, you will need a suction machine so that you can suction if any secretions start building up. Yeah, so thank you so much. I can see that the majority of our participants are able to understand the specific equipment that you need to manage certain patients. Now let's go into the details of what other specialized equipment is common and helpful in the care of ICU patients in general. What other specialized equipment is common and helpful in the care of ICU patients in general? Some of the specialized equipments have been covered by my colleagues. Again, the list may not be very exhaustive. I would just encourage you to make reference to our website, where you'll find a lot of literature and guidelines on how to set up a high dependency care unit or an intensive care unit of whatever level, whether it's level 1, level 2, level 3. You'll find very clear guidelines on some of the literature that you'll find in the on the website. So we'll just go through some of them very, very quickly. The list may not be exhaustive. So it is best always to classify the equipment into airway equipment, some of the equipment that will be required to manage the airway, breathing equipment, circulation equipment, plus other specialized equipment. So we'll follow the ABCD kind of approach. In terms of A, which is the airway, so we are talking about equipment such as a face mask. You may need oropharyngeal airways. You may need endotracheal tubes. You may need a laryngoscope that will aid your intubation if your patient starts failing to breathe on their own and you need to assist them. You need to intubate them. You need a suction machine and various other supplies and consumables that come with management of the airway. In terms of B, which is breathing, you need an ambu bag. An ambu bag would aid in ventilating this patient. And then you need a ventilator. So a ventilator, this is a machine that will help the patient with breathing. Then on C, circulation, of course, you need various monitoring systems, including a cardiac monitor that will be able to provide continuous cardiac monitoring, such as an ECG to monitor your heart rate, etc., etc. You will need infusion pumps. I'm sure most of our participants have seen how infusion pumps and syringe drives look like. These will give you precise dosages of drugs that you need to administer at specific rates. You will need central lines, okay, that will give you a very good and comfortable venous access. You will need defibrillators, of course, for you when you are resuscitating a patient who has gone in cardiac arrest. Then plus other specialized equipment that may include portable x-rays, arterial blood gas machines, because remember these patients that have got airway breathing problems, you will need to monitor how well they are ventilating by monitoring their arterial blood gases. You may need an ECG machine for you to be able to interpret the function of the heart. You may need an ultrasound. If you are able to have one, you need an ultrasound, plus various other equipment such as trolleys, etc., etc. So the list may not be exhaustive. Again, kindly feel free to refer to our resources where you will find clear guidelines of what equipment you need at whatever level of ICU that you would like to set up in your hospitals. So at this point, we are going to break out into 3 groups. So we'll have breakout sessions. So each group will be led by one of the presenters, myself, Papytcho and Hope. And we're going to discuss different subjects that
Thank you very much. We're back to the main house, if I can call it so. I like the breakout session because they give you the appetite to go visit the LRRC and get to read more. Because we cannot discuss everything within the few minutes that is allocated, but it's just to review the other material that is there for us to go read, for us to go understand it better. Okay. Dr. SPK, allow me to start with my group.
Yes, please go ahead. Thank you.
Thank you. In our group, we're discussing about care bundles. I would not be the rapporteur. We have our only one who voluntarily accepted to be the rapporteur, Joy. Sarah, please, will you give us the whiteboard?
Okay, thank you so much, Dr. Ntambwe. So in group 2, we discussed about care bundles. The first thing we talked about was to define what a bundle is. So we said a bundle is simply a collection of things or materials that when wrapped up together, for a certain purpose. Then we went further to discuss what care bundles actually are. So we said care bundles are just a set of interventions that when used together, significantly improve the outcome of the patient. So we said mostly these care bundles are usually come about from decisions that are made by a multidisciplinary team that sit together and put these things or the services together for the good of the patient. So we said usually these are supported by evidence-based research. Then we went further to talk about ICU setting bundles, in which we talked about 5. So the first was the ventilator care bundle, in which we described certain parameters that usually apply to this one. So one of those is usually there's the raised head of the bed to actually prevent aspiration in the critically ill patients. Then for the second one, we talked about the central line associated bloodstream bundle. So for this one, we talked about how to handle a central line, in which we said usually the central line can stay for a number of days before we have it removed to just prevent infection or sepsis in these patients. Usually we said it can stay for about 14 to 21 days. Then we talked about the third one, which was the Cooperator associated urinary tract infection bundle. So for this one also, we basically talked about handling of the catheters, like in terms of changing it if it's infected, or when we want to empty the contents in the catheter bag just to also prevent infection. Then the fourth one we talked about was the 1 hour bundles, 1 hour bundle sepsis. So in this one, we talked about the things you can do within 1 hour after you've diagnosed sepsis in your patient. So the first thing we talked about was you can obtain blood samples for culture. Then after you do so, you initiate your patient on antibiotics after you've obtained your sample. Then you can also measure the lactate levels in these patients, then as well as you can continuously monitor for their urine output. Then the last bundle was the ICU, sorry, I missed the word in the middle, bundle. So for this one, usually you want to, this is mostly, the part where you want to taper down on certain parameters as you are almost transitioning your patient from ICU. So you want to check on the spontaneous breathing trial. You also want to reduce your sedation, as well as you want to reduce your ventilation in terms of the equipment settings. Then the last thing we talked about was the syndrome known as a post-intensive care syndrome, which we said as clinicians we should be aware of, as well as you should talk to relatives so that they're aware of this condition, so that they can manage patients well at home in case the patient actually has this condition. So we said some of the things a patient can present with who has post-intensive care syndrome is that after ICU, they can have ICU-acquired weakness, where the patient is unable to carry out day-to-day activities and that their muscles are just weak. Then they can also have CNS symptoms such as memory loss, or the memory is affected, as well as they can have poor judgment yes. And then they can also have failure to sleep. Yeah, so basically this is what we discussed in group 2.
Thank you very much, Joy. That was a nice summary of what we discussed about. But of course, there's more that is there to talk about on this point. We just encourage our participants to go on the LRC. Please remember, registration, it's free, there's no charge. All you need is just for a bit of bundles. You connect on the website that has been shared in the chat, and then you have access to all the content. Thank you, Dr. Sipuka.
Thank you so much. That was a very, very interesting session, as well as a summary. So we'll go straight into giving you a summary of what we had discussed. As our group was talking about common complications in the ICU. So what are some of the common complications that can occur in the patients that we manage in ICU? So I'll invite Brian just to give us a summary, a short summary of some of the common complications that ICU patients may develop in the course of care.
Okay, thank you so much, Dr. Sipuka. So from the discussions we had in our group, commonly we have complications in ICU. So as we admit the patients, we need to be wary of complications. Hence, we need to have a plan on how you're going to respond to these complications. So some of the complications which we discussed include the sepsis or sepsemia, which can be associated with the ventilator, or infection acquired through the catheter, or prolonged use of non-invasive machines. Then the second one we discussed was the stress. This can be attributed due to if the feeding is not introduced early, this can lead into stress ulcers. Hence, we need to protect the GUT of our patient. Another complication we looked at was the equipment failure, which can be one of the critical instances that can happen. For example, maybe the vent has stopped working, or the patient has, the tube was dislodged, but we couldn't pick. So some of these are the complications which occur. Another one is pulmonary embolism, because of the patient is immobile. Hence, as they are coming in a critical condition, we need to plan for prophylactic medication to avoid the DVT or pulmonary embolism to these patients. Another one is the malnutrition, because the patient is unable to feed on their own. Hence, they need support from the persons who are taking care of them. Otherwise, they can develop malnutrition. Then the sixth one is organ failure, because the patient has stayed long in ICU and the organs are deteriorating based on the condition they are presenting with. And then also the other one we discussed was the pneumothorax, which can be due to high pressures of oxygen or accidental extubation from the patient themselves. So these are, in summary, the 7 common complications which we discussed as a group. Thank you so much.
Thank you so much. That was a brilliant summary. Indeed, the responses that came from the participants in the group. Again, the list may go on and on. Again, feel free to actually log to the website and access these materials. So the previous group discussed on the care bundles. Those care bundles are meant to sort of prevent the occurrence of some of these complications that we have listed. Remember, the moment you admit the patient in ICU, you need to be wary of these complications and institute measures early enough to prevent the onset of these complications in our patients. Thank you so much. So now we'll invite group 3. Group 3 will talk about the common indications for ICU admissions. I'll invite Dr. Piri and the group to give us a summary.
Okay. Thank you, Dr. Spuka. Our rapporteur was Dr. Chanda. Dr. Chanda, please.
Okay, thanks very much, Dr. Piri. So we looked at the common indications for ICU admission. And one of the things that was of importance in our discussion was that the patients that we consider for admission to ICU, they have to have a reversible problem. Okay, the problem that they are presenting with has to be at least reversible as we send them there for organ support. So one of the number one, we came up with 6 indications that can that we should consider when sending our patients to ICU. Number 1, we said that we can send our patients to ICU for close monitoring and observation. Then the second reason why we can send them there is for airway and breathing support. Then we can also send them there for circulatory system support. Okay, so patients presenting with low BPs needing inotropic support can also be sent to ICU. And also those that are presenting with elevated BPs that require close monitoring can be sent to them. Then the fourth thing that we talked about was stabilization of patients with acute medical conditions, such as patients presenting with a myocardial infarction, and also patients that are presenting with diabetic ketoacidosis. Okay, the number 5, it's patients that presenting with trauma, polytrauma patients that require complex management. Okay, so patients with trauma to the face that will probably require ventilatory support or airway protection in view of the imminent respiratory failure can also be sent there. Then the 6th thing that we talked about was just maximizing of comfort for patients that are suffering from terminal illnesses. And then we gave examples of some disease conditions as well that may require patients to go to ICU. So we talked about respiratory failure that can come from any cause. Then we also talked about acute myocardial infarctions, then intracranial hemorrhage patients, then also patients with renal conditions, and then also stabilization of patients that are having heart failure or shock. Yes. That's what we discovered. Hello, can you hear me?
Thank you so much. Yes, thank you so much, Dr. Chanda. I think that's a good summary of what we discussed. Dr. Spuka, are you still with us on the call? Okay, Sarah, we can go back to our presentation.
It's 17 hours.
Okay. I think while we're trying to get Dr. Spooker back on the call, I just want to thank my co-panelists for today, Dr. Spooker and Dr. Papytcho. We've discussed a lot about intensive care, who should be admitted, what are the anticipated complications, how do you implement a care bundle, how are patients monitored, and what is time critical care as well. So please feel free to go to the Learning Resource Center. The site has been shared in the chat box. Sarah has been kind enough to share the link. Please feel free to register, and all of these resources will be availed to you. So some of the key topics to review today is that we should remember that an ICU is really a separate unit in the hospital, but an ICU can be integrated into part of emergency care, into part of triage care, into part of the anesthesia, post-anesthesia care unit. We need physicians and nurses who work closely with other specialized staff to provide time critical care for these patients. An ICU needs close monitoring, so there's a need to invest resources for monitoring and support for failing organ systems, whichever organ has been identified. We need continuous patient monitoring systems and systems to monitor that these monitors and equipment are working. We need to realize the indications which patients benefit from ICU admission, because all of this ICU anywhere is a precious resource. It's a finite resource, which is limited by resource availability. We need to know that there are several complications, regardless of your best efforts. There are several complications that a patient will may have by virtue of them being critically sick or by virtue of them being admitted to a critical care unit. We need to know, implement bundles to prevent these complications and actively and aggressively monitor them. This is by the prudent use of care bundles. We also need to recognize what the post-ICU syndrome is, as this can have significant long-term impact on patients who recover post-critical illness. And most of these effects go beyond just the patient, but transcends into their families. So folks, I think that's a wrap of the key topics and practice change concepts for today. Sarah, I will invite you to give any closing remarks from Assist International. Sarah?
Thank you, Dr. Hope and Dr. Papytcho and Dr. Spooker for this excellent presentation. It was most informative. So just a couple wrapping up points. You can access all of the resources that were shared today, and the link has been put in the chat. It is the Learning Resource Center. So everything that you saw today, plus more resources, are all available completely for free. We believe education should be free for everyone. So please go on there, make an account, access all of this. Many of you have asked about certificates of participation. So certificates will be provided to everyone who has attended a live session from Dr. Papytcho and panelists by the end of next week. And if you don't get one of those and you want one by the end of next week, feel free to email us and we'll make sure that you get one. If you would like to join our WhatsApp group, here is the QR code to stay updated and stay in contact with everyone in this group. Our next session will be on July 15th, session 7. We'll be discussing defining ARDS, ARDS. And again, if you have any questions, please email us at echo@assistinternational.org. And we would like to thank all of our funders and partners for making this possible. Big thank you to Project Echo and Stanford for helping us with these sessions. So thank you all very much. Have an excellent rest of your week.
Thank you, Sarah. Thank you, everyone. Please register for free or join the WhatsApp group to get the information that you want.
Thank you, everyone. Stay safe.